So how can we diagnose drug-resistant tuberculosis? Well, the End TB strategy by the World Health Organization clearly calls for universal access to DST, drug susceptibility testing. That means every patient diagnosed to have TB should at least have rifampicin resistance detected as part of a DST algorithm. And in cities like Mumbai in India, where MDR is very widely prevalent, almost every patient deserves a DST. So in the past, we used to do DST selectively in just a few patients who are at risk of MDR. But today, especially in cities like Mumbai, there is a push for all patients with TB to at least have rifampicin resistance done as a screen for MDR. In the future, I think we should be pushing for universal DST for all tuberculosis patients in the entire country. Now, what is the quickest pathway to universal DST? Well, since cultures take 2 to 3 weeks to grow, the fastest approach to universal DST today is an upfront molecular screen with a test like GeneXpert, and then if the rifampicin resistance, then follow up with liquid cultures and other technologies to look at more drugs. So GeneXpert followed by additional tests is the fastest approach to universal DST. Now, the next slide shows you the ideal algorithm for DST. So in an ideal setting, you would begin with GeneXpert as your screen, and rifampicin resistance is the screen that the GeneXpert gives you. If rifampicin is not resistant, then you can stop the algorithm there and then safely conclude that your patient does not have MDR-TB and treat with the standard first-line drug regimen. If rifampicin, on the other hand, is resistant, then you have an obligation to follow up your patient to see whether rifampicin is indeed resistant and what other drugs are sensitive or resistant. The best and the fastest way to do it would be while you initiate empiric second-line management on the basis of rifampicin resistance, send off a sample for line probe assay as well as liquid cultures. LPA is available for first-line drugs. They pick up rifampicin resistance with very high sensitivity and specificity as shown on the slide. Isoniazid performance is not as good as rifampicin, but still quite high. And there are second-line LPAs available, which were recently approved by the World Health Organization, which can detect rapidly resistance to fluoroquinolones, as well as second-line injectable drugs like amikacin and kanamycin. Overall, the ideal approach to DST would be a rapid molecular screen using GeneXpert, followed by second-line LPAs to confirm RIF resistance and look for other drugs like quinolones and second-line injectables. And then ultimately, the best way of managing drug resistance is to do a complete phenotypic liquid culture-based DST, look at all of the drugs and their resistance profile, and then come up with a cocktail of drugs or a regimen that will have at least 5 drugs to which MTB are still sensitive. And there are guidelines available on how to create those MDR regimens.